Question two was, in your opinion, is there value in sending every patient who has been diagnosed clinically with HEDS for genetic testing to rule out other forms of EDS? I am wondering the instance where a clinical diagnosis of HEDS has been made and has turned out to be another form of EDS. So yeah, I think if you have access to genetic testing, you should get genetic testing. The incidence is fairly uncommon, where, at least in our registry, where we see an HEDS patient actually has a different genetically defined disease, not necessarily even a different type of EDS, but a different type of connective tissue disease. We do see that, and I think that's really important to know, because some of these other diseases can be very can change how the clinical management of that patient is. So I would advocate for doing genetic testing if it is available. Courtney, anything else to add with that?
I'm a strong advocate for all patients with suspected, even just very obvious, like clinically appearing HEDS, to get genetic testing if you have access to it or it's affordable for you. I just don't think there's any reason not to, aside from maybe not having access or the financial means to do so.
Next question was, what genes and mutations were discovered? It's believe me that we get that question a lot, obviously, and as I said, we can't disclose what the gene is quite yet. We're hoping that we'll get positive feedback from the editors at New England Journal, but just to give some context on that and how this sort of publication stuff works. We submit a paper to the editorial panel at New England Journal. Editorial panel then takes a week or two to review it and deem whether or not it's worthy to be sent out for review. Review goes then to probably at least 5 experts around the world in the field, and it is then critically reviewed. Papers never come back to the editor with a full acceptance, ever. And I have 125, 150 papers, and not a single paper I've ever written ever comes back with it being perfect. Reviewers will always ask for things to do, and the editors will always agree that the reviewers are right, that things need to be done. So it can be a lengthy process, not just, submitting it to the journal is one step, but then acceptance can be a lengthy process. But we're just waiting now to see what the editors and reviewers want us to do. We're prepared to do whatever they ask. How can patients get tested for these genetic mutations? So you can't right now. What normally happens, and what's happened with my previous studies where we've identified genes, it can be a lengthy process to getting these genes on gene panels, and that's obviously a goal and would be incredibly helpful, but it also so that may take a year or 2 years after the paper's published. A lot of times the companies like to see additional validation from separate groups to get these genes on gene panels. There's an entire review panel through the NIH that actually reviews these sort of genetic discoveries independently of the journal. So it can be a lengthy process. I will say that even if you're screened for the mutation that we identified and you do not have it, it does not change your clinical diagnosis. It will not change your clinical diagnosis. We know that there are going to be many genes out there, which is why we're still collecting genetic information through our registry.
If I
Yeah,
can
go ahead,
also
Courtney.
add about it not changing your diagnosis, it's also not going to change anything immediately if you do have the gene mutation. And that's something else I want to emphasize, because I think patients are really eager to get tested. If you already have a clinical diagnosis of HEDS, and then you get a gene panel once it's added, and then it turns out you do have one of these mutations, it's not going to change the care that you're receiving at this time. Obviously, our goals are to work towards things like treatments, but at this time, it wouldn't change anything about the care that you're receiving. I know that people are eager to get tested, and I know that that can be very validating. But for those who do have a diagnosis, whether you have this gene mutation or you don't, it's not going to change, or it should not change, the care that you're receiving.
Thank you for that, guys. I'm going to feed you guys some questions from the live chat. Dr. Gensemer, this one's for you. Do interns have to be American?
So right now, we're only able to accept interns in the US. We do want to change that. There's just a lot of hurdles with things like visas and other things that would need to be in place. We actually have been talking about this, and for 2024, trying to have our applications open a lot sooner so that we can make decisions earlier. And if we would take international applicants, that we could have the time to sort of get everything in place to have them be here.
Okay, and is it open to people with HSD or just HEDS?
I would say we're very open to people with HSD. I'm of the opinion that HSD is not very phenotypically or genetically different that we have shown yet from HEDS, and I have no issues with people with HSD applying. Great.
Dr. Norris, this one's for you. From Roland, should we be using more biopsy of tendons or skin to assess collagen size and stretchiness?
I don't know about tendons. It's way more invasive. Skin, it's always good to have a biobank and a collection of specimens. It's something that we're actively doing here, so that we can ideally have a collection of tissues and in the same patient have their blood, serum, and then also saliva, and so from that we can actually have so we can have a collection of approaches that really sort of get more at personalized medicine. So we would collect the DNA, be able to do sequencing the blood. We're currently looking for biomarkers that are predictive. So we need serum for that. And then the skin, of course, on biopsies, the skin can be used for multiple things, which could be of incredible benefit. One being, of course, aside from the biopsies, looking at fibril diameter is not the most trivial thing to do. But at least having a biopsy to be able to do histopathology, I think, would be important. But we'll be using it to generate iPSCs, or induced pluripotent stem cells. So we'll be able to maintain cell lines of the patients, or at least that's the idea. And so we'll be able to actually look at mechanistic causes in those patients. And then you pair that with the genetics, and then you can validate mutation pathogenicity in those individual patients by doing CRISPR repair alleles. So I think it's good to keep collecting. I think it's good to not only keep the skin collected in formalin, but also snap frozen liquid nitrogen to allow for additional genetic and genomic approaches that could be useful in the future.
Thank you. And have you heard of the CUSAC protocol?
Courtney?
I knew you were defer to me there.
Okay, maybe you haven't heard of it, so
we have heard of it. So I'll give my general feedback. For starters, with HEDS and other subtypes of EDS, we really don't know a lot about the biology, even in cases where we have a strong understanding of genetics. All types of EDS lack research in basic biology. And so the idea of taking supplements to target biology that we don't really understand is kind of premature. and really lacks any good science to support it. I'm not saying that there might be patients who have tried this and report feeling better. And I think that if you're doing something that makes you feel better when we have a condition that is so poorly understood, that is great. And I am so happy. But for me as a scientist, it's not something that I would personally endorse or recommend. I don't know if you have anything to add, Chip.
I really go by strict science. I mean, certainly there's personal reports and personal stories of people who have benefited from the Cusack protocol, and I think that's great. Like Courtney said, but you also don't know about the dangers of treating of combining all of these different supplements because the science is just not there, and the scientific benefit is doesn't make logical sense to me. Doesn't mean that it's not there, but I'm not a proponent of the Cusack protocol.
Thank you, Dr. Norris. And I think we have time for one more question. We have around 2 minutes left. What percentage of your patients in the registry have MCAD disease, not only MCAS syndrome, that is not positive markers, but still clinical presentation of abnormal mast cells?
That's a tough one. Courtney, do you have thoughts on that? We don't really.
Yeah, so for a little bit more on how our registry works and our clinical data. So we're not physicians. We're not personally seeing all of the patients in our registry. One, I couldn't imagine us seeing thousands of patients. But two, the goal was really to trust patients on reporting what they're experiencing. So we did ask for a clinical diagnosis of mast cell, which means that patients should have only answered the question yes if they have been diagnosed. I'm assuming that most of those patients, if they were diagnosed, probably had elevated tryptase, but it's totally possible that they saw a mast cell knowledgeable clinician who made a clinical diagnosis without necessarily having positive markers for mast cells. So we don't really have an answer to that question, but I'm sure there's some of both.